Assalamu alaikum everyone. Thank you for joining us. I welcome you all in 8th lecture of CPHQ Cohort II. Our speaker for today is Dr. Irfan, who will talk about the risk management and safety culture. He is working as a quality and safety manager in Qasim National Hospital, Saudi Arabia. He has done PharmD. He is certified Lean Six Sigma Black Belt and also certified professional in healthcare quality. He also holds a title of certified key performance indicator. He have extensive experience in field of pharmacy and healthcare quality. He has served various national and international organizations. I would like to welcome Dr. Irfan. Dr. Irfan, you can join now.
Yeah, okay. Anybody wants to speak before I continue?
No, you can continue.
Is the floor mine now? Hello?
Hello, Dr. Irfan, you can start now.
Okay, thank you very much. Bismillah ar-Rahman ar-Rahim. Thank you for the generous introduction, and thanks for providing the opportunity again to be with you after, I think, a couple of months or at least a year. So today I will be talking about risk management as well as patient safety culture. And what I knew from Dr. Sarawat that lots of our speakers, they had a talk about patient safety culture. So I will be just taking much time on risk management and whatever time left, so that I will be covering some of the slides from the patient safety culture. So we'll go through the risk management first. My slides not changing again. Okay. Is the slide changing so I can continue? Anybody can confirm, please? I'm on the learning
Yes,
object.
they are changing.
Okay.
Yes, they are changing. Yes.
So at the completion of this session, we will be able to describe risk versus hazards, types of risk and hazards, risk mapping, or how to establish a risk register in a hospital or in a particular department, risk management process or steps, and last few slides I will be talking about failure mode and effect analysis. So when we're talking about risk, what is actually risk? So the likelihood or chance that harm will happen if exposed to a hazard. So harm we define as physical or psychological, unintended physical or psychological injury. This is simply we define a harm. And hazard is a potential source of harm. We define hazard as like this. So now the probability of getting harm when something or when somebody or any process is exposed to a hazard, we call it risk. For example, let me just elaborate the two pictures that we can see on the right-hand side. One is a climber, rock climber. She's a professional climber who is climbing the rock. And another, we can see an aged lady who is stepping the stairs downstairs. So now the possibility or the probability or the chance that the old lady may have a fall, this is what we call a risk. On the other side also, the rock climber, that there is a probability or possibility that the rock climber may fall down and may sustain some injuries. So the probability or the chance that both of them will have harm or they will experience harm, this is what we call risk. And what is hazard in both cases? The stairs that the lady is stepping through is a hazard. The source of potential harm, what is the source? the steps. Number two, also her age, and if she's her pathophysiologic condition, if she's osteoporotic, and she's going with some support also. So all these things that make her vulnerable to a harm, this is what we call a hazard. On the other side, the rock itself is a hazard. So whatever exposes you to a harm, there is a source of that is a potential source of harm, and we call it hazard. And the probability of getting harm is risk. Now, what to do if you have anything that you see that in daily operation? Of course, you will find too many risks in operation on daily basis. So what shall we do? Shall we stop doing those activities? What shall be done? In that case, we define risk as either acceptable risk or unacceptable risk. You have to define them. You have to classify them and distinguish them. So acceptable risk, even the risk is there in operation or in a process, but you still work on that process. You still acquire it. And the examples will be how you define acceptable risk. A potential good is judged to be greater than potential harm. So for example, if you're giving chemotherapy to a patient who is having CA, or you are doing amputation, for example, a diabetic foot patient, so you have to go for amputation, or any other surgical intervention that whatever we do, the surgeons do. So in all these cases, the patient experiences somehow harm, whether physical or psychological. But we still go through chemotherapy or radiotherapy or for amputation or any surgical intervention. Why do we do that? Because the potential good for the patient is greater than the harm that we anticipate. And in a second acceptable risk, or the criteria for accepting a risk, is the skill level is judged appropriate for an activity. For example, the surgeon is doing an operation. So why we do allow the surgeon to do operation? Because he is having credential, he is privileged, he's having experience. That's why we allow the surgeons to go for a particular surgery. We won't allow the general surgeon to do orthopedic surgeries or neurologic surgeries. Why? Because they are not trained for that. They don't have the proper experience or the privileges for that surgery. So when you assess the skill level is judged appropriate, like for example, on the right-hand side, you see the rock climber, because she is skilled for this activity. In that case, you consider a risk as an acceptable risk and you undertake the activities. Now, on the other side, what are unacceptable risks? So there are again two criteria, like not justified based on any on evidence. So especially in medicine, we say that evidence-based criteria, you're doing something which is not an experiment, which is not a new study. So if it is something is a new study or something not based on evidence, so we are saying this is unacceptable risk. You should not carry out that activity. The second criteria, the potential harm is judged to be greater than potential good. In the previous, in the acceptable risk, we were saying that the potential benefit is greater than the harm, but here the potential harm is greater than the potential good. And examples are giving antibiotic for a non-viral infection. Once you know that the patient is not going to get benefit of using antibiotic for a viral infection. So of course, the patient is going to experience somehow a harm, then why you will give antibiotic for a viral infection, for a non-viral infection? So in that case, it is considered as unacceptable risk. And the other example, like surgical intervention while conservative therapy is an option. You can manage the patient conservatively. Why will you do a surgical intervention? Choosing not to use standard vaccination. Giving IV medicine when oral is an option. For example, any medication having the same bioavailability or having the same efficacy, the same level of efficacy for oral and the same medication for IV antibiotic or whatever other medication, not only antibiotics. So why would you use still to give medication parenterally once the oral is an option? So in that case, the risk that reside in that process is unacceptable. Overpooling inventory and expiration, another example, that these are unacceptable risks. So now we know the risk, and then we categorize them into acceptable and unacceptable. Acceptable, accept them and carry on. Unacceptable, either you abandon the risk, abandon the process because of the risk inside, or you just modify the process, and we will be talking about those techniques, that how we can make the risk acceptable to us. And the goals, of course, that do more good than harm. And we have to look for the risk versus benefit assessment, and then patient caregiver must be involved with the judgment. So whenever you have a risk in any process, you have you must have these three goals. Now, what is hazard? As I define a source of potential harm, and these are examples: a surgical intervention, medication administration, parental lines, inventory, communication. These are different examples of hazards. As we mentioned, the stairs, the pathophysiologic condition, the rock itself, different, whatever, even the floor itself, to some patients might be a source of potential harm. And in that case, we call it as a hazard. Polypharmacy, multiple medication to a patient, even geriatric, and age becomes a hazard for them to get harmed. So these are different examples of the hazard. And now on the right-hand side, you can see a simple illustration to know that when we categorize the risk, we are saying that there is zero risk or negligible risk, tolerable risk, moderate risk, extreme risk, and some are calling high risk. How we define, like negligible, minor, moderate, high, and then extreme risk. So the illustration is very simple and self-explanatory. I'm not going to explain this, but this is how the only extreme risk, if you can see over here, the person is inside the cage and he's feeding the lion. So the possibility of getting harmed by the lion is what? Maximum, that is extreme. So 5 out of 5, you will score it. The severity is also 5 out of 5. Why? Because if a lion attack on him and the cage is closed from the outside, or there is no protection, he doesn't have any kind of protection. So what will be the consequences of that attack? He might either die or he might sustain some serious injuries. So in that case, we see the possibility it is extreme. There is 5 out of 5. So you multiply 5 with the 5, there is the probability is 5. The chance of getting harm is 5. And the severity also will be, in this case, 5. So 5 multiplied by 5, the score will be 25. And 25 is above 15. When we score, when we get the RPN, it is above 25. We categorize it as extreme risk. Now, in this case, what is the hazard? Anybody can chat. What is the hazard in this case? We define a source of potential harm is a hazard. So what is a hazard in this case? I don't see anybody writing. So if it was clear, we said that the source of potential harm, what is the source now? A lion is a hazard. Okay, let me see. Yeah, of course. Okay, somebody is writing feeding. That could be an operation, but actually the source of potential harm is lion. Feeding will not harm anybody. So the lion is a source of creating harm to the one who is feeding. So a hazard is a lion, and the risk, we define the possibility, we multiply the possibility with the severity, and here we receive a quantitative risk, which we call RPN, risk probability number. I go to chat, so I cannot then go. Okay. Okay, now for risk management, we require some structural elements. And of course, you need to have a risk manager in a hospital, or either even quality and patient safety manager, who must have a domain of managing the hospital. risk. So he need to have 5 characters, like it requires authority. Without authority, we cannot have an effective risk management processes in place. Visibility, you need to be, the risk management team need to be visible. They should properly communicate, effectively communicate with the team, with the teams or with the departments or even with the stakeholders. They need to have a coordination with either CEO, CFO, IPC, Director of Nursing, QIPS, Compliance Officer, and so on, whatever department, clinical and non-clinical. And in the last, with the authority should come accountability also, not only just to maintain or to attain authority without having accountability. So these are the structural elements for an effective risk management process or for a risk management procedure. They should be available in a hospital. Okay, what kind of risk we have in a hospital or any healthcare facility? What are the types of risk, the major risk or the categories of risk that somebody may have or the organization may face? So we face risk related to patient care, related to medical staff, related to employees, property related, organizational risk, that is whether claims, communication, and IT, financial risk, and others. So these are broad areas that where you can define or identify further risk in these 7 major domains. Okay, let me just not go through the poll because people are taking time to chat. So let me just go to the slides. I will. Okay. Now we know about the risk and the hazard. What is risk management? Because in the beginning, I said that our topic is about risk management. So risk management is nothing, it is just an organizational effort to identify and assess the risk and then developing strategies to manage those risks. Very simple. We have to identify the risk, then analyze those risks, and at the end, we should develop some strategies to manage those risks. And once you identify the risk and you just raise your hands up or you just note it down in a risk register, you don't do anything on that, you don't have an action plan, so you don't do anything. You identify a risk, but you are not managing it. So the job has not been done. So this will include identification, then analyzing the risk, and at the end, you must have certain strategies to manage those risks. These are 5 steps in the risk management process. In the first, you have to identify and analyze the loss exposure or analyze the risk, then examine alternative risk management techniques or treatments, then select the best risk management technique or combination of techniques, implement that, then monitor. It's exactly as PDCA or PDCA cycle, you can do the same way because everybody knows PDCA, plan, do, study, and act. And risk management process is exactly the same way you can implement. In the planning, you identify the risk, you assess the risk, and in the do phase, you test the best technique that you have selected. In the check phase, you assess the risk management techniques, whether it is effective or not. In the act, you just implement and then you repeat or monitor. Now, how do you do it? We said the first is identify and analyze. Values, perils, consequences of loss, whatever. There are 2 ways. Now, how to identify? There could be formal ways, informal ways. In the informal, there is whether data coming from claims, from KPIs, from patient complaints, from flow charts, from RCA that you conduct, because these processes are not meant to identify the risk directly. You will be doing something, but out of that process, out of the root cause analysis, or creating a flow chart, or going through the KPIs, you might be coming across some risk areas that you identify, and then you mention, then you monitor that, yeah, this is a risk area, and we should register in, or we should log in a risk register. There are some formal ways for identifying the risk, which is incident reporting, OVR system, occurrence variance reporting system, or incident reporting system, whatever you have. Sentinel events tracking FEMA, failure mode and effect analysis, and device reporting. So if you have different ways of reporting those incidents, sentinel events, or conducting the FEMA, whatever name you call it, whatever way you name it, but these are formal ways of identifying the risk in your organization. So once you identify the risk, then you have to quantify it. How do you quantify? And what we call analyzing the risk. As we mentioned that for quantifying the risk, you should do two things: to analyze the severity of the risk, and then to analyze the probability and the consequences of the risk, and the probability or the chance or the likelihood of that risk that may happen. So you multiply both, and then you get an RPN, which we call risk probability number or risk priority number, and that is a quantification of the risk. With that quantification, you then classify your risk as whether it is low risk, medium risk, high risk, or extreme risk. This is the key that I have shown. This is a risk matrix table, a universal risk matrix table. On the x-axis, we are scoring the impact or the severity or the consequences of the risk. On the x-axis, we put likelihood or the probability of the risk to occur. Okay, and again we put it as rare, unlikely, possible, likely, and almost certain. There are definitions that almost certain it is happening every day. Likely, you think that it is happening, like for example every week. Possible, once in a month or every month. Unlikely, like once in a blue moon. Rare, that happens once in 10 years, 5 years. So this is how you define by the frequency of occurrence. And catastrophic, which is having extreme risk, then major, moderate. There are definitions that we had to, once you are saying that this risk is catastrophic, for example, as we explained the example of feeding a lion in a cage without having protective equipments. So in that case, the staff who is feeding the lion may lose his life. So of course that is catastrophic. And in that case, we will classify this risk as 5. We will score it 5. Now, the likelihood that he might be harmed, we classify also, or we score it almost certain, because he is inside the cage, in front of a lion. Okay, and lion is not a cat. It's not a pet animal. So of course, he's going to attack the person, even if you are feeding. He doesn't have friends. So the probability or the likelihood that he will be attacked is also extreme, and he is not having any safety equipments with him. So there we will score it also 5. In the impact also 5. 5 multiplied by 5. So it will be extreme risk, which will be 25. So this is how we score or how we quantify our risk. And this is an example that you can maintain a risk register. You can do it on an Excel sheet, or you can even have a ready-made you can download through Google that you can just Google it and you can download, or you can develop your own. But this should include ideally these columns. What is the risk index? That is the risk number. Then you put a risk category, whether it is operational risk, whether it is strategic risk, financial risk, or legal or compliance risk, or patient safety risk. So there are different categories, 7 categories or 7 main domains where you have to classify your risk. Then the description of the risk, that is detail of the risk, that what is the risk actually. Then you score it, that is likelihood and impact and the risk level you receive. You can have a conditional formatting in the Excel. So once you put a 4x4, it will automatically give you an extreme risk, and it will become it will turn red, so that you can do in the Excel easily. Then you put the current controls, that what current controls you have for the risk being identified. If you have current controls, you will put, if you don't have even, you can put that no current controls exist. After that, what are required actions? And here, once you analyze this risk scoring, you should do then what to do next. What are the actions that are required? And here you will put, I mean, not only an individual, the risk management team, or with whoever you analyze and identify the risk, they will devise certain actions that these are required to mitigate the risk or to avoid the risk. Then the owner, who is the owner of this process or this risk, you will mention, you will write their titles or their positions or even the names, whatever you like, and expected action time completion, the status, and then so on. So you have to do it in this way, and you can then reevaluate your risk based on your hospital policy, whether every 6 months or whether once in a year. That depends on your hospital processes. So, but it cannot be reevaluated after a week or after a month or even after 2 or 3 months, because it takes really time to manage an existing risk in any process. This is how we have, this is an example that we have done in our hospital. That is, we identify hospital-wide risk. And here we put it into heat map. The heat map is nothing. It is just showing the risk, the identified risk in one slide. Here you can see in this slide that on the left-hand side, there is green color, so whichever risk will fall here, so you know that these are low risk. Then a yellow color, that will be moderate risk, and whatever reside in the orange pattern, that will be high risk, and extreme will be on the right-hand side, on the upper hand side. So, and then there is a legend or a key also, that strategic risk RS1 refers to what? RS2, because in the figure, you can just see RS1. What is RS1? Nobody will know. So RS1, you have to put a key also, that RS1 is MOH referral volume. And if you want to go in detail, then you will go to the risk register. So this is how you can do risk mapping. And risk mapping is needed to show your risk in one slide to executive directors or to hospital management, because they don't have time to read such condensed slides. They won't understand it. So for management, once you present your, because I did it for a risk and governance committee, board committee. So to the board, I'm presenting such slides. I cannot present condensed slides, which they don't have time to read and to understand it even. So this is how you do for executive levels to present your risk register. Okay, here is a key also, that low risk is score 1 to 3, 4 to 6 is moderate, 8 to 12 is high risk, 15 to 25 are extreme risk. Okay, next is you identify your risk and you analyze the risk. Now, step 2, what to do? We should examine alternative risk management techniques. And these are basically 2, risk control and risk financing. Under risk control, we have 5 further methodologies or techniques. That is risk avoidance, risk prevention, risk reduction, risk segregation, contractual transfer of risk. And in the risk financing, we have 2 again. Let me give you an example. For example, risk avoidance. If you don't have, for example, NICU facility, neonatal ICU, you do not have in the hospital, but you do have L&D, labor and delivery unit. So if a baby is born in the L&D and the baby needs an immediate NICU admission, where will you transfer the baby? So in that case, once you don't have the facility to accommodate those patients or those babies who require immediate NICU admission, the best alternative or the best risk mitigation or risk avoidance technique is to avoid the risk. You should not operate an L&D department once you do not have a NICU. Either you stop doing L&D services, or you develop your NICU facility. Risk prevention, or you can have the same thing like in let me tell you an example of risk prevention. For example, for you do not have an IV room where you are preparing your IV medications, okay, and there is lots of complaints, or whether even there is data that's showing that the patients are getting infections because the medications are prepared on nursing stations. So what do you have to do in that case? You either develop your IV room, or you train the nurses enough to practice aseptic techniques. And in this way, you prevent the risk. You cannot avoid it, but you prevent the risk of getting the patient getting central line infections. The other way, reduction, once you have an IV room, you establish an IV room, but still you cannot just stop over there that I have an IV room and nothing more is required. You have an IV room, but you still need to observe the competency of your staff who is working in the IV room. You need to every 6 months or annually or biannually to have a check on the laminar airflow hood, where the IV medications are being prepared. Are you taking some samples regularly? So all these processes, whatever you are doing, these are risk reduction strategies that you try to reduce the risk of patients getting infections from IV medications administration. Then there are segregation. A best example for segregation, I can say, independent double checking. Some people or some hospitals or organizations or departments may think that independent double checking or double checking, it is a redundant process. It is a waste of time. But segregation, you split one process into 2 or 3 steps. It is one way of reducing the risk or controlling the risk. Okay, in the 3, 4, and 5, you just what do you do? That you selected alternative risk management techniques, then you apply the best technique that you have selected. And after that, you monitor the outcome. Once you apply the best technique, then you reduce and monitor the number and size of payments, identify the most economical approaches of risk financing, quality and patient safety. These are various indicators that you apply to the process that you have recently adopted or you have implemented. So you apply different outcomes, different KPIs to that process to monitor the outcome of that you change a process, you change certain things, but whether you are progressing in a right way or you are not. So that's why you have to monitor the outcome as well, and then I look at the cost. So this is all about the risk management process, where you start from identifying the risk, then you analyze, then you quantify it, and after that you select risk reduction strategies, you implement the best, and then you monitor the outcome. Now, we'll go to FEMIA, which is one way or a tool to identify risk in whether in a process, in a product, or in a design, in a department, or on a hospital-wide. So failure mode and effect analysis is a proactive. One thing has to be noted, that is a proactive approach. It's not a reactive. What we call RCA, root cause analysis, is conducted after the event happens. So we call it a reactive approach. But FEMIA is always done before something happens. So we call it a proactive approach. Proactive and sequential. You just don't do something that you sit with the department managers or with stakeholders, and you just listen from them and you record everything. And you know that now I know the failure modes and the failure causes and the effects. No, it is a sequential approach for capturing all possible failures. Failures in design, in a process, in a product, or in a service, in order to measure, to either prevent or control such failures. So what we do, for example, you starting a new process. Let me give you an example again. You are going to establish or to start an antibiotic stewardship program. So before you start, before you embark on the program, you should have a feasibility study. That what you need, how many staff you require for this program. You need management acceptance for this program. So in order to get management acceptance, what kind of feasibility study you need to submit? Then even from the department manager, how to convince him to have this program. Then if you have a resistance from the physician side or from the department, whether from ICU, in ICU, or medical department, surgical department, so how to kill that resistance? Okay, if you don't have trained or skilled staff, how to develop the skill level of them? So all these things you have to identify before you embark on the process. And what you have to check for failure modes, that what could go wrong before applying the process, what could go wrong, and what we say failure modes. Then causes, why would the failure happen? Now, for example, you are saying that the management may not approve this program. So this is one of the failure mode. Okay, why the management will not approve this program? Causes, because no budget, low budget, they are not interested. They want just to look for the money. They want to know that how much you will be saving, and. Okay, then failure effects. Okay, what if the management do not approve? What will happen? So what would be the consequences of each failure? Maybe the whole team who were preparing from 6 months on this program, that they have to start an antibiotic stewardship program, and within one disapproval, now what will be the model of the team who were working on 6 months? Where would they be? So these will be the effects, the failure effects. So these 3 questions we have to ask for every step in the process. This is an example that we have conducted. I will just go to everybody. You can just Google this on IHI website. What we need to do when you are conducting a FEMIA, so you need to draw a 9-column where you will write first the steps in the process. In any process, you will put steps of that process. Okay, whether it is an establishing an IV room, whether it is establishing a clinical pharmacy program, whether it is a unit dose dispensing program, or whether it is training and development, whatever, you will write all those steps. Okay, then failure mode in each step. How many modes? How many failure could happen? In where could the failure be happening? So you will write all those modes. And the causes of those failure, cause could be 1 or could be 10 of a single failure mode. Then failure effects, what could be the consequences of those failure? If something happens, failure happens, so what could be the consequences? Then you just give it a scoring, likelihood of occurrence, how probable that the failure will happen, and you score it from 1 to 10. 1 is least and 10 is most likely. Again, on the likelihood of detection, this failure, how likely or how detectable is this failure? Okay, for example, you know the mode of management, that everything that you're giving to them which is not creating direct finance, they are disapproving. So likelihood of detection is this is too easy now that you understand the mode of the management, that they might be disapproving this. So this the score will be here 10 or maybe 8 or 9 or 7. Severity, of course, the consequences, again, you have to rate it from 1 to 10. So if it is the consequences will be severe, that will be 8, 9, 10. If it is less severe, so it will be 1, 2, 3, 4 up to 5. At the end, you have to write actions to reduce the occurrences of those failures. And this is an example of unit dose dispensing or state medication dispensing. So I'm not going to explain it. The basic idea is to know about the methodology, that how you conduct a failure mode effect analysis, that you should know the steps in a particular process or in a product or in a design. Then you need to know, or you need to list anything that could go wrong during that step in the process, which we call failure modes. Then you go into failure causes, that why would the failure happen? And you enumerate multiple, it could be 1 or multiple causes of a single failure. Then you're writing the effects of those failures, and then you quantify it by likelihood of occurrence, likelihood of detection, severity of that failure. You get an RPN number, you multiply each. Here you will multiply 3, the detection, the occurrence, and the severity. And then you put actions to reduce those failures. So this is about risk management. The second half of the presentation will be about patient safety culture. So if you have any question, meanwhile, while I go to the next set of slides, you can unmute yourself, ask questions, or even can type it before I go to the next session.
Hello, Assalamu alaikum. Sir, I have a question regarding PRN number, that how we will calculate it, and if a detection has high chances of detection, then we will give him 10 marks, or if a detection have minimum 2 marks or 3 marks.
Your voice is distorted, but I just got only that how to calculate RPN, where we multiply the severity, occurrence, and likelihood of detection. And the rest part of your question I didn't hear. That if anybody heard, so can repeat the question, please.
I think Dr. Irfan, the question was same as you understood. He wants to ask that how you calculate RPN. But Mr. Atik, if you can just write the question again in the chat box, it will be great.
Yeah, my question is that how we will detect about the detection. If there is a high chances of detection of any error, then we will give him 10 marks, or we give him 1 or 2 marks.
Can you please just write down, because your voice is not being clear? Just write down in the chat so we can
what I'm
read.
hearing, he's saying that if it is least detectable, so from where we have to start the marking, where if it is least detectable, so the marking should be from 1, 2, 3 until 5, or if it is least detectable, so the mark should be starting from 10 to 9, 10, 8, and like this. So if it is detectable, you have to give it because if it is detectable means that your work is easy. It is the process is making it easy for you to know or identify the risk. So in that case, you give it higher number, so you get the maximum RPN and you work on it.
I think the question, I think you got your answer already. And Dr. Irfan, you can continue with your presentation. Thank you for answering the question.
Okay, shall I go to the second set of slides?
Yes, sure. We can see your slide. You can continue with that.
Thank you very much. So as I heard from Dr. Sarawat that our speakers have talked about safety culture. So I will be just going through, I will be having a quick review with you. I don't want to repeat the same things, whatever they have discussed, but the topic is pursuing a safety culture, system, and professional accountability.
You can, yes, yes.
Okay, so I'm an objective. The objectives of this session is to describe the role of safety culture as a component of safe and effective care, the levels and components of safety culture, then measuring and interpreting safety culture. Everybody talk about the safety and safety culture and just culture and patient safety culture, but the main job is how to measure a safety culture. And when you measure it, how to interpret the results. That is exactly where the main job exists. Explain the concepts of just culture and apply techniques for implementing a culture of safety. So culture is what? Culture is just, we are saying that traditions, the way we do things around over here, the way we see things, this is how we define culture, right? So it is actually the way we do things around here, but shared values and beliefs that interact with a system structure to produce behavioral norms. So the norms are the behaviors that we produce, and that what is evident to the people and the customers, whether it is internal customer or external customer. I mean, whether it is employees or whether it is patients or patient companions, whoever come to the hospital. So they just see the behavior of the staff or the behavior of the organization or the behavior of the departments or the individuals, but they cannot see the underlying beliefs and the values which has created or which has developed those behaviors. So whether the behaviors are bad or good, these are evident to the people. And this is an analogy I have shown in the picture, that is an iceberg analogy, that what is hidden from the people, these are beliefs and values. And these are actually the values and beliefs which is interacting with the system and producing behavioral norms which people see. Here, so what we see is behavior. We do not see values and beliefs. If the values and beliefs in a particular system or in a particular culture are good, they're producing good behaviors. But if it is bad or if it is weak, so even if it is vague, it is producing bad behaviors. Let me give you a clear and easy example. Maybe some won't like it, but I have observed this. For example, let me explain in a way that Pakistani people, when they are abroad, I have experienced it. They respect everything. I will give you an example of KSA. They respect the rules of KSA, they respect the rules of any organization they work with, they respect the rules of policing wherever they go to bank, they stand and really, they are like that nobody is noble than him. It doesn't mean that they are pretending. Why they are doing this? Because there are values and beliefs that have created this culture over here. Now, for example, if I'm going to bank, everybody is in a line. Everybody is in a queue system. Nobody can cross another one. So once nobody is doing that, why should I, or how would I dare to cross somebody? Even if somebody, whoever he is, regardless of the nationality, if somebody is crossing me even in a grocery mall, I will push him back. Why you are crossing me? Because this is a system over here. So with whether it's in a healthcare or with policing or wherever you go, everybody respect the system. Why? Because this system is based on beliefs and values, which has created a pattern of behavior in every single, whether national or expatriates. It's not only for Pakistanis. But the sad part is, even if I'm going back to Pakistan, the same people, they behave very well even in the airplane. But as soon as their feet are on the airport or on the ground in Pakistan, everything changes. Everything changes. As the airplane lands, nobody sit on the seat. Why? When they go to the queue system, nobody cares. If somebody saw them, they start yelling. Why? Because we know there that there is no values and beliefs. Nobody cares the rules and policies. Nobody cares about the ethics. I mean, I don't mean that 100% of people's, but it is majority. Okay, the policing, we know that they are just there to get something from us. So even if they want to stop us, we don't do that. They are asking something. Maybe they are asking for bribes. So this is how the system is bad, not the people. The same person over here behaves well, but he or she doesn't behave well when he or she reaches Pakistan. Why? Because the flaw is in the system, not in a person. So what we see only behavior, but we do not see the values and beliefs that leads to such behaviors. And that's why what is important is not the behavior. What is important is to develop or is to establish the values and beliefs of a particular system. Okay, now this is about culture. Patient safety culture is an integrated pattern of individual and organizational behavior based upon shared beliefs and values, but only adding one thing over here, that continuously seeks to minimize patient harm. And this is what we say, patient safety, how we define a patient safety culture. A culture where we continuously seeks to improve the patient safety or to minimize the harm to the patients. Now, culture eats process for lunch. What is important? Whether process or a culture. As I told you, the behavior is important, or the beliefs and the values. So no process is important, whether you are writing policies, SOPs, guidelines, whatever you are writing. But if you don't have the right culture, you don't have established the right culture in your organization or in your department. So all those protocols, those guidelines, those policies and procedures, those SOPs are useless. You have to develop a right culture in your organization. Okay. Now, what role the culture plays in patient safety? How it improves the safety of patient? So if you can see over here, here is a negative correlation, a scattered plot showing a negative correlation between the hospital survey and patient safety culture and the patient safety incidents, or I can say safety incidents. On the y-axis, the safety incidents are being shown. On the x-axis, the score for patient safety culture is being shown. So it is showing, for example, you start from 75 or 80%, the hospitals, organization, or departments who are having maximum score for the patient safety culture. So there they have least number of patient safety incidents. But as you can see, it is coming from the right-hand side to the left. So then the percentage or the score for patient safety culture is reducing, and here the patient safety events is increasing. So it is having a negative correlation that hospitals who are having a safety culture will experience least number of patient safety incidents. And those who are having least number of patient safety incidents, it means that their patient safety culture is at appropriate level. Another study shows here is a positive correlation between hospital survey on patient safety and patient satisfaction. Patient satisfaction is shown on the y-axis, and the scoring of patient hospital survey and patient safety is on the x-axis. So here is a positive. You can see over here that the behaviors and attitude of hospital employees can directly affect the pain, discomfort, health, and recovery of patients. So here, of course, if I'm satisfied, who is being surveyed? The staff. And how we measure the hospital survey and patient safety culture, we get a survey from the staff. So if I'm satisfied, I give good marks. I showed positive attitude, and while I'm filling the survey, or I'm conducting the survey. So this is a hospital staff who are having, for example, the compliance is at 75%. So my compliance or my satisfaction is reflected in patient satisfaction as well. If I'm satisfied, if the hospital takes care of my rights, my salary, my sick leaves, my vacations, my rights, whatever. So my health, even if they're caring about me, of course, I'm caring about the patients. So this is having a direct or a positive correlation between the hospital survey and patient safety culture, or higher scores on patient safety survey and on a patient satisfaction. So this is how the culture is impacting the patient safety. The next, we are talking about the levels or components of any organizational culture. So you can see over here that the components of any patient safety culture, whether it is having three components: assumptions, beliefs, and values. And here it changes into behaviors. In assumptions, again, we divide each component or each level into two. That is whether desired assumptions or desired value or desired beliefs or desired behavior and observed. For example, in assumption, we assume in a safety culture that safety is a system property, and it is a system which is important for the safety. System means whether it is engagement of the leadership, good infrastructure, the skill level of the staff, the number of the staff, and whatever the infrastructure available and the technology, of course. So this is assumption that the system plays vital role. But in reality, people think that it's me because of whom the system works. And individuals plays important role. It is individuals' competency level which is important for the patient safety culture. So these are this what we observe, and which is wrong. So what we assume, it should be showed in what we observe also. In beliefs and values, we say in a patient safety culture that teamwork is important for a patient safety culture. But once you go to implementation side, once you go to individuals or to units or even to hospitals, so there the people think that autonomy is a cornerstone, not the teamwork. So they're writing in policy something, they're speaking in meeting something, that the teamwork and teamwork and teamwork, but once in practically they don't work in teams. Behaviors, desired behavior, we are saying that round to assess catheter appropriateness. Okay, to assess the appropriateness of catheters, you need to conduct regular rounds to assess whether the use is appropriate or not. But actually, people are not doing such rounds. So one thing we perceive and another thing we observe. So in a safety culture or organizations who are matching or who are on the same page, what they perceive and what they observe, they are on the peak. But those where the differences happens in what they perceive or what they are writing in policy and procedure, or they speak in a meeting, and what they really or how they really practice, so there they are lagging. And here it defined that where you stand. For example, once you are measuring your safety culture level, you conduct a survey. So again, you quantify your level. You are saying that my department or my organization is either at reporting level, or the culture we have is just culture, or the culture we have is a flexible culture, learning culture, and or HROs. So what are these? Let me explain over here. James reasons, he's saying that the safety culture is having the following. For example, in a reporting culture, the staff they report any incident or safety event that is happening. That's it. They don't do anything more than that. Or there is no perfect system about this. Just the people or the staff, when they find something wrong, they just report it. And this culture we call a reporting culture. Another is just culture, where in a just culture, if you do something good, you are being rewarded. But if you don't do good things, or if you do bad things, where something safety events are happening, or where the safety is compromised, so you are made accountable for that also. So there is, I can say that you have accountability and also no punishment environment, because many hospitals, they are saying we have safety culture, we do not blame, we do not punish the staff, and we don't do this, and we don't. No, at certain point you should make the staff, or you should keep the staff accountable, because if the staff think that nobody touches them, why would they care about the safety events? So a good performer there is same as a bad performer. So in a just culture, you keep just a balance between both. Then flexible culture is a culture in which an organization is able to reconfigure themselves in the face of high tempo operations or certain kind of danger. For example, COVID was the best example to test the hospital competency or the resilience of organization. So those who did not perform well during COVID, it means that they did not have flexible culture. But those who changed their processes just because of the COVID and they really perform well, they change this risk into opportunity. They are having flexible culture. And then it comes HRO. HROs are nuclear power plants, are aviations. These what we call HROs, high renewable organizations, that there is a zero tolerance for any near misses, not for the errors, zero tolerance for the near misses. Now, how to improve? You need to continuously measure the beliefs and behaviors, put an action plan, and implement the practices. And then you need to do it continuously and consistently. It is not a one-time job.
Dr. Irfan?
Yes, please.
I'm sorry, I'm interrupting you. We have more 20 minutes to go. So if you can try to end up in 20 minutes, it will be very kind of you.
Yeah, I will be just going to how we measure the culture. That's it. So I'm not going to spend time
Thank you so much.
Goals of culture assessment. Okay. Now, what we need to do, everybody talk about culture, safety culture, patient safety culture, just culture, flexible culture, this culture, that culture. Now, how should I know the organization I'm working with is having what kind of culture and who should measure it? From where, how, by what ways? So HRQ, Agency for Healthcare Research and Quality, they have the best tool, and every hospital or a national and international organization, they are applying this tool to measure their culture. It is having 42 items, which are categorized in 12 composites or dimensions. 9 dimensions measure the culture at department or unit level, and 3 dimensions measure the culture at hospital level. Then these are different composites of those. There are 12 composites, starting from communication until teamwork within units. Okay, teamwork across the units, teamwork within units. So these areas are being covered in this survey. You just need to adopt it, nothing to do. You just need to adopt it, conduct it by whatever way, through Google Sheet or through manual processes, or even you do it through SurveyMonkey, whatever way you conduct the survey, you just adopt it and you carry on. But it's not that your job is not done once you conduct the survey. The job is when you interpret the results. For example, you have in your organization 500 employees and you conduct a survey and you got 70% of responses across different units, clinical, non-clinical, managerial, and whatever. But now how to interpret those results? That is the key. So there are different ways that how you can identify, how you can interpret the results that you get. Reasons are GEMS reasons, components of safety culture, what I explained above, that there is organizations is either having learning culture, flexible culture, just culture, HRO, and informed culture. So with these questions, you can identify your organization is at what level. The lowest is reporting culture or informed culture. Identify unit-wise areas in need of improvement. Conduct external benchmarking if you have on national-wide studies have been conducted. So you can conduct external benchmarking to compare the level of your organization with other organizations, or you can conduct internal benchmarking. For example, nursing with physicians, physicians with paramedics, paramedics with administrations, or with non-clinical departments. You can conduct such kind of benchmarking as well. And understand reverse worded items. These are very crucial to understand in the survey. Now, how do you do it? GEMS reasons is saying that if you want to know that your organization is having a reporting culture, so you need to adopt, or you need to measure those dimensions or composites out of the 12 composites that were being shown in the HRQ survey. The one composite is frequency of events reported. So you have to select questions or composites particular in the survey to know that the culture you have in your organization is reporting or not. Non-events reported, okay? O means that is outcome measure, and U is for a unit, and H is for a hospital-wide. So this is just a key that you can use. For a just culture, that your department or your organization is having non-punitive response to errors. So you have to select those questions to score them to know whether the culture that you have in your organization is a just culture or not. For flexible culture, then you have to or the flexible culture against those composites, that is teamwork within the units, staffing, communication openness, teamwork across the units, and hospital hands-offs. For learning culture, you have to go through the given 6 or 7 dimensions or composites. So once you have 12 composites, you conduct the survey, then you select particular composites to score your culture, whether it is a flexible culture, learning culture, just culture, or informed culture, or a reporting culture. If you don't know which question or which composite to put to measure what level or component of your organization culture, so you are going to interpret your results in a wrong way. Okay, external benchmarking. I'm not going through it. Let me just reverse solid items. Okay. Now, reporting culture, how would it work? For example, there are 3 questions that you selected from the survey that you have conducted to know whether the culture you have in your organization is reporting or not. When a mistake is made, but it is caught and corrected before affecting the patient, how often is this reported? Clear stand-up question. So 60% of the staff responded that it is when the mistake has happened and it is not, it is corrected, sorry, before it reaches the patient, so it is reported. 60% of the staff is saying that this is reported. So now from this, you can know now that your organization is reporting the near misses or not. The second question is, when a mistake is made but has no potential to harm the patient, how often is this reported? And if the mistake happened and you know that there is no potential that this mistake will harm the patient, so is it reported? 68% of the staff is saying that a study has been conducted in a particular hospital, that they are saying that yes, these are being reported. If 10% are saying these are not reported and the justification is that this is not going to harm the patient, then you know that how potential errors are not being reported, and then you put an action plan that how to make the people report such potential errors or such potential incidents. Okay, and then here you put an action plan. I'm not going to in detail of the action plan, that how you put an action plan to improve your reporting within your organization. The second level of your organization is a just culture. Just culture, what we said, that non-punitive environment, a balance between non-punitive environment and fair accountability. So there are again 3 questions. You have to identify these 3 questions, because once you conduct the survey and you don't know to measure against which composite, so you end up somewhere that you conduct a survey but you don't know how to interpret it, then how will you take and how you will put an action plan? You cannot correct the things happening there. So you have to ideally put these questions to know that whether your department or your organization is having a just culture environment or not. Staff feels like their mistakes are held against them when a mistake happens. And I'm questioned that, do you feel if you do a mistake and those mistakes are held against you? And I'm saying yes. So it means that we do not have a just culture environment. We have a punitive environment, okay? And you receive like 30% of people are saying that yes, the mistakes are held against us, but 70% are saying no. So you're doing well, I think. Then when an event is reported, it feels like the person is being written up, not the problem. And these here are reverse worded items. In the first one, he's saying that the mistakes are held against them. In the second one, if you receive a compliance 80%, it means that the staff did not understand either question A or B. So you need to measure the compliance or the satisfaction level of the staff with different questions, having different words but same meaning. So here they are saying that if an safety event is reported and it feels like the staff is being written up, and the quality department is coming and blaming and blaming and asking and calling the staff for meetings and giving disciplinary actions, taking disciplinary actions and giving warning letters or doing salary deductions, it means that you're working on the individual, not on the problem, not on the system. So 36% of the staff is saying that yes. And remaining, that is 64% of the staff is saying that no, the mistakes are held against the system. Okay, the next is then a flexible culture. So flexible culture, we say the teamwork within units and teamwork across the units. And you measure such cultures by having assigned questions. I'm not going in detail of those questions again. It continues the flexible culture. Of course, communication openness that you have to, this is one of the composite out of 12 that you have to test your culture as well. And there you say that whether we have flexible culture or not. For example, staff will freely speak up if they see something that may negatively affect patient care. Now, for example, a pharmacist is dispensing a medication and he or she noticed that this medication, this is an error, medication error, and it is going likely to cause a harm. But she or he knows that the one who prescribed is a director of the department, or he's a consultant, or he is this and that. And there she just closes eyes to the error that is going to happen, because I'm afraid of the reaction that the director of the department or the prescriber he may have. So in that case, the staff do not speak freely. They don't speak up. They don't report. They don't talk. They don't stop something from doing somebody from doing wrong things. So here you mean that you do not have a communication openness, and here that will be describing your culture as non-flexible. Okay, and here we have a learning culture. So in the learning culture, we assign the composite as supervisor manager expectations. And here we have several questions from that composite. If the mistake, for example, if mistakes are happening and it's been investigated and been reported, so the knowledge we gain from those errors or from those safety events, so are we sharing or not? We sharing with the staff? Do we give feedback to the initiator or not? So if we don't do that, it means we don't want to learn from our mistakes. We don't generalize it. For example, a particular staff committed an error. It is a mistake or error or whatever, human error. So we just speak to that particular staff in office, in close offices. So we don't share the same mistake with others, because we think that if we share with others, this particular staff morale will get down, or particular staff will be thinking that I'm being blamed for this error. But you don't need to mention the name of the staff, but you need in generally to discuss those errors with your team, so the same errors is not repeated or is not happening with other staff. Okay, so this is how you conduct a survey, and I would strongly recommend that you conduct, whether the quality department or you even conduct within your unit, you just adopt the HRQ survey, you conduct it there. And how you interpret this is very difficult, but you have to just go through, just search some like what I showed, that particular question has to be assigned to a particular composite. You cannot assign a question from communication to to non-punitive environment or to a flexible culture or something else. So you have to assign particular questions to a particular composite and a particular composite then to measure the culture of your department or within your organization. Just let me, in a just culture, as we mentioned that we have accountability, let me go through only one thing. Last 5 minutes I will take into when you are managing or when you establish in a just culture, we're saying just culture is nothing, it is just managing behavioral choices. So what behaviors you are expecting? We are saying that to manage the behavioral choices, and there we call it a just culture. Okay, now we need to know the behaviors, the human behaviors that we may expect or it can happen. So human behavior or human error, we categorize it into three. That the behaviors, the human may behave, whether they will conduct human errors or they will have at-risk behavior or reckless behavior. So human errors are inadvertent action, inadvertently doing other than what should have been done. For example, you are preparing a medication. Instead of putting a label on, let's say, heparin, you put it on Clexane or whatever else medication, because both looks alike or both are mixed with each other, or you are just putting multiple levels. You're having 3 vials of paracetamol and you have 4 levels and you put it on 4 paracetamol while the 4th level was for something else. So this is a human error. This is a simple slip, lapse, or mistake because you were occupied with another job or you were overwhelmed. There is no deficiency in the skill level. It is simply a human error. Okay. Then how you act on such errors? You don't terminate the people. You don't just reduce their evaluation. You don't just reduce their salaries or deduct their salaries or give them warning letter, because these are human errors that is happening, that can happen to anybody. Another is at-risk behavior, behavioral choice that increase risk where risk is not recognized or it is mistakenly believed justified. For example, I'm giving almost always a simple example. You are driving and you are approaching a signal which is going to turn red. But you think that while I will cross, I can just pass by. So before it becomes red and I will get a flash, I will get a penalty, I can cross. And that time you mistakenly justify the risk, or you did not recognize the risk well. And then you got a flash and then you paying 3,000 real payment for crossing a signal while it is red. So this is at-risk behavior. Another is reckless behavior. You know that you cannot approach the signal before it becomes red. And once you are crossing it, you are sure that it will become red, but still you are saying, I don't mind. Even if I got flash, I don't mind. I have much of money to pay. So in that case, it is a reckless behavior. Or you think from the other side, who will be coming before they start or before they have push an accelerator, I will cross over. So I will not have the possibility of getting accident, but let it have a flash. I don't mind. So this is a reckless behavior. So for each behavior, you should have different level of punishment or different level of whatever correction strategy that you might have. And these are for human errors. What you do that you manage through changes in choices, processes, procedures, training, design, environment. At the end, you console the staff who involve at-risk behavior, the errors involving at-risk behavior, you coach them. You tell them that this is not acceptable. What you do is not acceptable. You manage it through removing incentives, you creating incentives for good habits, or you increasing situational awareness. And the errors which are caused by reckless behavior, there you start punishment. The punishment could be where you want to punish the staff. And I think we are done. I will not just go through the examples that we have put to know how to know that whether it is a human error or at-risk behavior or reckless behavior. There are some examples I have put, but will not go through it. So I think this is how do we define who we are. That's from me, and any question you have, so it is your turn to ask or to chat.
Thank you so much, Dr. Irfan. There is a question. If there is only one composite question result showing greater percentage, but the rest 2 to 3 composite questions showing no response at all, so how can we interpret that survey data?
Yeah, good. If, for example, composites, if it is for different level, for example, those composites are being assigned to know whether it's a flexible culture or just culture. So of course you will measure them separate, but the same composite, for example, 3 composites apply to know whether my organization is having a learning culture or a flexible culture or no. And there are further multiple questions out of those composites. So the symbol is you give weight to those questions. For example, you are saying that every question bears the same weight. Okay, then you just take an average of it. For example, one question compliance is 50%, another is 40%, another is 70%. So you sum it up and you take an average, and here comes your compliance rate. So the easiest that you give it the same weight to every question. So you can take an average of that, and the average will be your overall compliance rate.
Thank you so much, Dr. Irfan. If anyone has questions, so you can ask, please.
Dr. Irfan, I have one question from my side.
Yes.
You discussed about FMEA. We should consider this as a quality improvement tool or approach. Like if I want to do a FMEA, I should say this is a tool or this is an approach.
Yeah, actually, it is a tool that is being used to identify certain failures. So anything that you need to identify, that is a tool that is helping you to detect your errors, and before it happens, you fix them. So anything that is helping you to fix something, that is a tool.
Okay, so the PDCA we are doing, this one is approach.
Yeah. Again, we are saying PDCA, we are saying it's a quality tool, a quality improvement tool. But of course, it's an approach that by definition, it's a tool. It's not an approach. But how you are using that tool, that we call it as approach is only a English term. That is, how do you approach to different problems or methodologies? Yeah. But everything that is helping you in detecting the problems, fixing the problem, or improving the problems, we call these our quality improvement tools.
Okay, thank you so much.
Any more questions from participants?
If you have any questions out of the chat, so we can even get those questions. Here all, if you have, okay. I think we answered this question, or it is again the question is repeated, but there is 2, 3 composite questions showing no response at all. So how can
Yes, sir,
it is unlikely to have no response. Now I think this is a different question. For example, we have a certain composite. For example, we are measuring communication. Okay, we have 4 questions in a composite of communication, whether it is across the department or within a department. Out of 4, the 2 questions, those who participated in survey, they responded, but to 2 questions, they had no response at all. So it is very least likely. I cannot say that this is going to happen, but if it really happened, then you just take the compliance rate of what we have measured. Where you don't have the data, you have 0 data. So of course you cannot measure something on it, but sure, if you get that, it means that there is something wrong. The participants did not understand the question. To different questions, out of one composite, they don't really respond, there's something wrong. So you have to, before you conducting the survey, it's not just only adopting. You need to create, and we did in our hospital. We did the first time that we conducted in 2019. Believe me, that nobody's was going to respond because they were afraid that I'm going to collect some data and I'm going to share it with management for some reason. And this is what people think. And this is how the culture defines at that time how serious the culture of our hospital was, that people were so afraid that why I'm collecting this data. And then we kept on engaging them. We kept on educating them, that see how the results will, we did some study in front of them and we showed to them that, see, I'm not getting your name, I'm not getting your ID, I'm just getting your responses. So it is for a purpose to improve the environment, not to fix the individuals. And there the people started to and then we explain also to them that how to respond, what is the meaning of this particular question. So you have to explain to the people.
Thank you so much, Dr. Irfan. If anyone has questions, so you can ask on our WhatsApp group. In the end, I would like to thank Dr. Irfan for providing us this information, and I must appreciate the way you deliver this information with best coded examples, and for sure your precious time. And I would like to thank for all the participants for your intention. I think we should close the session now.
Okay, thank you very much again for having me. And
so much,
I hope that I have tried my best at least to convey the message on both topics.
Yes, sir. It will be
very helpful. The participants have anything that I can improve for myself, so they can even chat or email or whatever the way that they can give feedback. So I would appreciate that.
Okay, sir. Thank you so much.